All right, welcome back to another episode of Paw Patrol with your host, Dr. Jeff Dykes. Tonight, I'm joined by Dr. Patrick McEneaney. Thanks for joining me tonight.
Thanks for having me.
Yeah, absolutely. So, you have quite the podiatry practice going. So, you are in the Chicagoland area. You went to school in Ohio and then did residency in Cleveland and Chicago. And now you practice in kind of, would you call it Chicagoland or Northern Illinois?
I'd call it Chicagoland. We're very much up north, but we're starting to creep down south too.
Yeah. So, how many practices do you have now?
Yeah, we're at 16 practices at this stage of the game.
Wow. With how many physicians?
19.
Wow. So let's walk back a little bit and take us back to when you first, got out of residency and you went into, did you jump into private practice right away?
Yeah, I joined a practice in Cary, Illinois, and it was a single doctor practice. There had been an associate there before me. He left, and I kind of walked into a half busy clinic. And so that was 10 years ago. I worked there for about 5 years. And then one day the owner's like, listen, in 6 months, I'm closing the place if you don't buy it, or I'm selling to somebody else. So if you want a job, you better buy it from me. And hadn't been looking at it at that stage in the game, but it just kind of, fell into the cards. And, that was the start of this journey.
So take us we'll kind of go step by step because I don't think anything happens easily or overnight, but take us back to when you took the step from one practice and you started to think about growing to expand that. What was your initial thought process of why that might be beneficial?
Well, I was about a year and a half into this journey, and I had three doctors. There was me and two others, and we had 5 treatment rooms in one office, and we were working 7 to 1. Another guy was working 1 to 7, and another guy was working like 8 to 5. And we had so many patients, we couldn't see them all. We had 2 guys working on Saturdays, and just physically couldn't see everybody out of the space we were at. And so we were at the point where we were about to start turning patients away, or patients were saying, we can't get in for a few weeks. We need to, we're going to go somewhere else. Mm-hmm. And so it kind of became this little aha moment, like, the practice at the building there had been built out forward, backward, and up. And we were landlocked and there's really nowhere else to go. Mm-hmm. And so it was either we move to a different building or we go to a different office. And what I did is I ran the demographics and realized that about 20% of our patients were coming from, about 2 cities to the west of us. And so I looked at that and said, well, if we put a practice there, I can siphon off the patients we need to without cannibalizing the whole clinic.
Right. So how far away was that in terms of miles?
About 6 miles away.
Okay. Because I assume that there's someone's probably looked into this. So I work in a multi-specialty group. I used to work in an orthopedic group, but I'm sure in private practice, there's an ideal number of miles that you want to separate your practices from each other so that they're not, like you said, cannibalizing the practice. And so that seems like a reasonable amount of distance. But is there an ideal distance that you want to keep away from each other that you don't harm the existing practice?
Well, it depends on population density.
Yeah.
So, if you're in a town of 10,000 people, you could be 20 miles away and still cannibalizing.
Right.
With us, we needed to cannibalize because we were so busy we couldn't do that. And so by siphoning that off, it allowed the other clinic to have a little relief. I mean, because we were literally running through lunchtime. We were an hour behind at times. Mm-hmm. And it wasn't because we weren't giving good service. Like literally both doctors would be sitting there staring at each other and we just didn't have rooms cleared. And so, a lot of it depends, again, on population density, how many rooms you have, and, the way your clinic flows.
So how in the original, most of my listeners are kind of younger and want to see what the different practice models are out there. So specifically talking about private practice, when you were kind of by yourself or then growing into the 3 doctors that you had, how did you handle billing and coding and advertising and, scheduling and clinic manager? How did you handle all that stuff?
Well, it's kind of tough when you don't know what you're doing. So,
right.
Luckily I had worked for the practice for 5 years. So, I had a good idea how the practice ran. I knew what kind of marketing worked in our area. We were kind of marketing light at the time. And so, I was able to kind of push into some more marketing and do more than we had been doing before. But a lot of it is you kind of learn as you go, and
Sure.
there's no playbook for this. And a lot of people have ideas. A lot of people will tell you what worked for them, but what works in your area might be different. Still to
Sure.
this day, with 16 offices, word of mouth is one of our biggest advertisers. No
Hmm.
matter how much money I dump into Google, no matter how much, how many billboards I put up, and everything else I do, the word of mouth is still so big because patients, are looking for, they can find anybody online, but they're looking for their friend to say, I saw this doctor, he did a good job for me, he took care of me, and I clicked with him.
Yeah, you're probably not going to beat that in terms of recognition, word of mouth, for good or for bad. I think they say that a negative comment spreads faster than a positive comment. So,
Well,
word of mouth,
absolutely.
yeah, word of
And
mouth.
what you
Sort.
have to
Go ahead.
do is you have to, and we all run into difficult patients, and a lot of times the difficult patients are very vocal. And I know
Yeah.
docs that just when you have a difficult patient, they say something to turn them off, so they leave the office and they can move on to somebody easy. But that's still somebody that spreads your reputation. And so, one of the things I've always done is I've always spent more time with some of those difficult people because some of them are just difficult, but others are frustrated themselves. They're in pain. Other people are brushing them off. Maybe they have some quirks that other people don't want to deal with. And so some of those people can be some of your biggest advocates over time.
Yeah, kill them with kindness. That's usually what I do if we have grumpy patients. And usually by the end, I've got them smiling and turned it around. So not every time, but usually if you spend enough time and kind of get on their level, you can kind of turn that around, turn a negative into a positive. So, with that original office, how much staff did you have? Did you have, because I've worked in private practice when I was in residency, and they'd usually have like one person who ran the front desk and then would run back and take the x ray too. How much staff were you running on back then?
Well, we were running real light, and so we had we when we had two attendings full time. We had two medical assistants. We had a front desk person. We had another part time front desk person. We had one person doing just billing, and then we had an office manager who was doing billing and all the behind the scenes work.
Mm-hmm.
But we were taking our own X-rays, we were doing our own casts, molding for our own orthotics, taking our own stitches out. We did everything. The MAs pretty much put people in room and they processed the X-rays.
So from a billing standpoint, because at my orthopedic office we had our own billers as well. So there's the two different options, as far as I understand it, is you can have your own billers slash coders, or you can outsource that for a percentage of your billing and collections. Is that correct?
Yes.
So what is the pro of having in-house billers?
So for in-house billing, you can control what happens. And so, I like to know what we're collecting for. How are we collecting? What are we saying to patients? Are we being sympathetic to our patients? We have patients who can't afford stuff and we still provide the services, and, we work on, payment plans with them. Billing companies may not do that. They can be very harsh. They can be abrasive. You don't get to know what they're saying to your patients. And other times with billing companies, what they'll do is, they're paying staff to collect your money, and if they're getting a percentage of that, and someone owes $14, how much time are they spending having their staff call somebody for $14? They're probably not, because to them it's not going to be worth the ROI on that. So my staff will call people for all the money because
Mm-hmm.
that's what I've trained them to do.
Yeah,
And so there's a trade-off of sometimes they take the low-hanging fruit, and people who owe less than $50 they don't even call,
yeah.
because again, getting someone to call them when they're getting less than 10% on something, it's a negative for them.
So do you still have in-house billing, or have you ever thought about outsourcing it? You
Well,
still haven't.
anytime you have like a billing issue, or you have somebody who you let go from billing, you always think, why am I doing this? Why don't I outsource this? But in the end, again, if you've got good systems and your team's collecting well, using a third party company, nobody's going to care about your money like you do.
Mm-hmm.
And so utilizing your own team who you can motivate and you can train to do what you want them to do the way you want to do is very helpful in retaining patients.
Do you have a set amount of money that you expect to collect, or how would you keep track of, aside from training them well on the front end, how would you keep track of whether they are doing what they're supposed to do correctly and collecting the correct amount of money? How do you kind of monitor that?
Well, we've got a big billing team right now. What we do is I have a revenue cycle manager who I work closely with and who my COO works closely with. And if you scale this back to when I was smaller, I'd have a billing manager who would work with the rest of my team. And what we do is we give them a stack of claims. We want you to get through this today, and we expect that they get through this. And if they don't get through it, then we ask why not. Why aren't we getting through this? What's the holdups? What are the ones that are difficult? And then the ones that are difficult, maybe we push up the chain to somebody more experienced, and then have somebody who's less experienced do the easier stuff.
Sure. So let's talk pros and cons of private practice. I think that's kind of a sticking point for especially students and residents who are looking for jobs. Am I going to go into private practice, VA, academics, orthopedics, multi-specialty? What would you say the pros of private practice are?
Well, I mean, the nice thing with private practice is that the sky's the limit. If you get in a good situation with someone who gets you on a salary or salary plus commission basis, the sky's the limit. I've got guys making more than orthopedic counterparts in my practice, and because they work hard and they're always pushing to do more and more and more. If you're complacent, if you're one of those people that really values being done at 4 o'clock every day and doesn't want to see a lot of inpatients and doesn't plan on doing a lot of surgery, then, sometimes a hospital or multi-specialty group's better because they give you a big salary. You see whoever they tell you to, and at the end of the day, you're done. But if you're one of those people that likes to, continue to run forward and likes to really push and likes to achieve more, I think you can achieve a lot more in private practice. I have friends who've gotten to hospitals and they're like, listen, I need to make more money. Can I see more patients? And they're like, well, what do you need to see more patients? Like, well, I need another MA. And they go, well, we're not budgeted for that this year.
Mm-hmm.
Next year, come and talk to us. But we can only do one patient every 15 minutes and new patients are 30. And you're like, but I'm not making enough income on my bonus. And they go, well, that's not in the budget.
Mm-hmm.
And so what I've seen is I've seen docs who do really well. They get a lot more money up front working for a hospital system. But at 3 years out, maybe 4 years out, they cap. And what happens is that the RVU bonuses change, the incentives they get change. And what happens is their third year, they're making more than they do their fourth year, or they stay flatlined for several years, and they get kind of in this situation where, some of the best years of their career, they're just kind of sitting where they have this ceiling they can't get past. Where a lot of times in private practice, you continue to climb each year.
Sure. So I know some people who have worked for hospitals and the people that are listening. So you get on an RVU contract, which means they expect you to hit a certain basically amount of work that you complete for a set salary. And then potentially there's a bonus if you hit a certain number of RVUs. But I know of some contracts where there was a set number of RVUs and then they call it a donut, basically a number of RVUs that you're not bonusing until you hit a much higher number. So effectively you're working for free for a long time until you hit that bonus structure. So just be aware of that when you get out into practice. So as far as private practice goes, what do you think are the biggest downsides?
Well, you don't always have the support that you'd like. Me as an owner, everything falls on me. And if you're a doc in a onesie twosie practice, there's a lot more headaches that you may handle that you don't have the support around you for. As a bigger group, I have more different types of people. I have a full-time maintenance guy, I have a full-time IT guy, I have a pet orthist. I have a lot of other things that other practices don't. So that makes it a lot easier for the doctors who work for me. But in the end, you're still responsible for getting yourself new patients. And anybody who's joining private practice, you have to understand you're marketing yourself every day. If I go join a big hospital system, they pay people tons of money to make sure that patients are coming in, and the marketing you have to do is minimal. And so if you're not a self starter, a self motivator, private practice may not be there for you. Whereas if you're not being in a big hospital system, they've got 2 or 3 people that are their job to get you busy.
I would imagine one of the benefits of growing your practice, aside from income and just growing the practice, is usually a good thing. Sharing resources. So, and if you're in a one office practice and you have an office manager, you're paying them a certain salary to manage one office. But if you're growing and you still have that same office manager, your costs are stratified, you're spread out amongst multiple practices that each have income. So can you talk about how to share the resources, whether it be office manager or billers and coders or whoever it might be, office staff, MAs, amongst multiple offices? Can you talk about how that works?
Yeah, so I'll give you one example. So, you know, obviously when you first start, we weren't working with cloud-based programs. I'm 15 years out in practice. So cloud-based programs weren't everything. So we had, a server, and we had, an internal program that we were working off our computer system. And so, I had I knew a lot about computers, but not enough. So, we'd either have to hire someone to come in for, 180 bucks an hour anytime we needed him, and he was only available when he wanted to be, or we would pay for a service, and the service you would call into, and you would call them, leave a message, start a ticket. They would call you back when you had time, and you had to work it out with them. And if you couldn't work it out with them, then they would come within 48 hours to fix the problem. And you can imagine how your system being down for 2 days was a problem.
Yeah.
And so what happened is I started looking at this and looking at the amount of money we were paying for this and the service we were getting. And it hit a certain crux where you're like, well, maybe I need to hire an IT person full time for me. And again, the same sort of thing happened with maintenance. We had 4 offices, and, toilet goes down, and the plumber says, well, it's $250 to come. And then he comes over, and it'll be $300 to fix your problem. And then all of a sudden you're like, wow, this office needs to be repainted. A light bulb went out, and all these different things happen. And you start looking at what your bills for maintenance are, and you're like, it'd be cheaper to hire somebody. So you constantly have to be looking at like what your fixed costs are for things. And sometimes you can get a contract with somebody where you get a certain amount of hours a month from them at a lower rate, and you have essentially like a part-time maintenance guy. Or, you look at, okay, it might be time for a full-time person. And so you constantly have to be reviewing your bills, seeing what stuff costs, and saying, how do I maximize this so I get the best service that I need at the lowest cost?
That makes a lot of sense. It's hard to try to figure that out, though, right? Because if you have 2 offices, you're like, it doesn't make sense. 3, maybe 4. You grow, and certain things start to make a whole lot more sense. But trying to figure out that cutoff of when the dollars start to make sense, I would imagine would be difficult.
Well, you just have to constantly be, in my earlier days, I'd be working with, I had an accountant I worked with closely, and he would look at things and say, wow, last year you spent this much on maintenance, and then you start looking and be like, wow, I can hire someone for that same amount, and they're around all the time to do anything I need them to do. Mm-hmm. Okay, now it might be a good time. And sometimes, sure. You're like, hey, I'm probably a year away from this. Well, with all the extra service you get, it might be to put in for that now, so that you don't have to wait till that time hits and you get the extra service that you're looking for. So mm-hmm. It's a constant, evaluating cost versus benefit type of thing.
Sure. When you started growing your practice, did you acquire other practices, or did you just acquire office space and hire someone to fill that office space?
So, yes, both of those. Okay. So initially, the first practice I bought that I worked there for, and then after that, the second one, I had an office manager who took over for me when I first bought the practice. She worked for me for about a year, and she had previously worked with a primary care group. That primary care group sold to the hospital. One of the doctors pulled away and started up a practice again. And so what happened is she worked for me for a year and then went back to the doctor she used to work for. Well, when I was short on space, all of a sudden I get a call from her saying, hey, we're putting up a 12,000 square foot building. Do you want 3,000 of it? And this is the time where we could get patients in. Mm-hmm. And I'm like, perfect. This place is nearby. I've got a new referral source next to me. And so that's kind of what led to that. And so the next 2 practices were also startups. And after that, everything else I've been working with has been acquisitions.
How do you value a existing practice? Because I've heard 2 schools of thought. One is based on the collections, and obviously if you own the practice, you're gonna, just like your car, you're gonna say, no, my car's worth this, and the dealer says, no, it's not, it's worth that. You're gonna think highly of your own thing. And so that is one way of thinking of it. And the other is to say, your practice isn't worth anything. When you leave, I'll open up across the street and all your patients will come to me whether you're there or not. I've heard both sides of the coin. I'm not involved in private practice in any way, but what are your thoughts on trying to value a practice to acquire?
So the easiest way to put this is the practice is worth whatever someone's willing to pay for it.
Sure.
And so, back in the 80s, guys were paying, 1 to 1.5 times last year's collections. Practices don't go like that anymore,
Mm-hmm.
especially for smaller practices. The overhead's gone up a lot over the years, especially since COVID. Gauze is up, 18%, gloves are up 13%.
Right.
All our employee costs have gone through the roof with all of this. And so the margins on private practice have become a lot smaller. And so the days of getting these huge sums for your practice is not what it used to be.
And the
And
reimbursement rates have not gone up accordingly, just so that we're clear on that. That's why your margins are shrinking, is because the reimbursement rates have not changed, if not gone down sometimes.
I had a very wise person that told me when I started in practice, he said, "You'll never get a raise." He said, "You will get paid less from the insurance companies every year. The only way you get a raise is if you find a way to work harder or smarter."
Mm-hmm.
And it's something I've taken very seriously since then, because you have to do this in order to continue to get yourself where you need to be.
So throughout that process of acquiring other offices, I assume that not all of them went perfectly smoothly. Did you have any that kind of didn't turn out quite like you thought, or it fell through, or wasn't quite as amicable as you thought?
Yeah, I've had several deals that have fallen through. You have people who are shopping around, start promising you things, saying, "Oh, well, we'll do it for this," and
Mm-hmm.
with in the meantime, you get a call from your friend, be like, "Hey, so and so's trying to get me to buy their practice." I'm like, "Yeah, they sent me a contract,"
Mm-hmm.
and so there's a lot of people that for a lot of people, you know, when they sell their practice, this is their life's work.
Right.
For me, I've acquired 16 different offices. So for me, it's just another acquisition. For them, it's their whole life.
Mm-hmm.
And so, there's two different sides of the coin in the way you look at this. And so, people are very, can be very hesitant on selling their baby away. And, they have what they feel like it's worth. And sentimental value is very, very strong one for people. And so, that's why I work with my financial team to really look what the practice is worth. I always look at what they're billing, what they're not billing. Is this a practice that's not doing a little surgery and I can add some surgery to it, increase revenue with it? Is it a
Mm-hmm.
practice that is at the top of their game right now? And now you have somebody that's going to leave, you're going to bring a new person in and it's not going to be as productive.
Mm-hmm.
So you have to look at what the market share is, what the competition is. You have to look at what the payer mix, the population density. People think that there's a simple equation where you should get this percentage of what they collected last year, and unfortunately, it doesn't work that way. I wish it was that simple.
Mm-hmm. Have all of the acquisitions been someone retiring, or have you brought on an office and then had them work for you
Oh
as
no,
an
I've done all of
associate?
it. I've had guys that have handed me the keys and I've never seen again, and I've had guys that have been working for me for 5 years after they sold to me.
Sure.
And
I think,
so, it really just depends on what the goal of the person who is selling is looking for.
I think
Now,
that's kind.
one of the
Go
things I
ahead.
do recommend is that I have guys that will come to me and like, "Hey, I plan on retiring next month. Do you want to buy my office?" And I think that's a big mistake when people make this, because some of these docs, a lot of them have an idea in mind of when they're thinking of retiring. I know
Mm-hmm.
docs that are like, the end of 2024, I'm done. And they tell me this 10 years ahead of time. And I got other docs who are wishy-washy and aren't sure, which is fine too.
Mm-hmm.
But I think docs who are, if any docs who are looking to sell or are thinking about it, this is a process you should start 3 to 5 years before you do this.
Mm-hmm.
Because as these docs start to cut their hours and wind down, their practice becomes worth less and less. And they're like, "Well, 4 years ago I was way up here, but now I'm here, but you could bring it right back here." People don't pay for where it was, they pay for where it is now.
Mm-hmm.
And so I think it's really important for people who are looking to sell to really have like a 3 and 5 year plan of where they want to be, because they'll get the most value for it.
Sure. So we talked a little bit about reimbursement. how do you negotiate your own insurance rates once you become large enough, or how do you view the reimbursement of insurance rates when you're in private practice, maybe in a very small office, or when you start to grow a little bit? Do you start to have any more bargaining power?
So when you're a small practice, you're at the mercy of the insurance companies.
Right.
If you're a practice starting up and you're trying to grow, and you get in a fight with Humana and say, I'm not taking anything less than this, they'll say, great, there's a guy down the street that'll take it. You're out of the plan. Call us again in 3 years.
Mm-hmm.
And so you have to be real careful when you're smaller. Now, there are people who are part of IPAs. There are people who are part of PHOs, and one of the things in our area, we have a very strong PHO
So what
through
is
our
that?
hospital system. A PHO is a private health organization.
Okay.
And so basically what happens is that there's a group of doctors that it's an independent group, but it's through the hospital. And what happens is that any doctor who's on staff can join that group. And then the hospital system uses all of those people to negotiate contracts.
I see.
So me with 19 doctors, I can go to Blue Cross and negotiate,
Mm-hmm.
but Advocate Aurora can turn around and say, all right, we're going to take 20,000 doctors and negotiate.
Right.
Who's got more power?
Yeah.
The more power always comes with the bigger size. And so in our area, because of population density and because of the state we're in, there's a lot of opportunities for these organizations to join up with them and let them do the negotiation for us. Now, positives of that are, again, size, equals power. But, the group can also decide, we're going to push more focus towards OB-GYN, and the hospital system who's helping run this can say, yeah, we want to get more reimbursement there. We'll take less from podiatry. And you have no control over that.
Yeah.
So it's kind of you kind of have to watch it closely. You have to see what's in it for you. But in Illinois, we've had people who insurance companies are mailing them or faxing them contracts saying, here's 50% of what Humana was paying of Medicare for Humana. Take this or you're out. You have 3 days to decide.
Jeez.
And
Yeah.
you can take all those patients, get rid of them, and then what happens when like 3 more insurance companies do that to you?
Yeah. Yeah, it's a horrible system. I think we can all agree on that.
Yeah.
When you acquire a new practice, I'm picturing, I'm in private practice, I've got a small practice, I'm collecting a salary, but I don't have a whole lot of extra money just laying around. How do you pay for a new practice? Is it something that you get a loan? Are you paying for it all up front? You say, hey, I'll pay you this amount up front, and then as the practice continues, then you'll get X amount over the next couple of years, or how do you do that?
Yeah, I mean, there's a lot of different ways to do it, and I've done it every which way. So, I've done it where, I've told the people, hey, we're going to pay X for your practice. I'll give you this as a down payment. And then for the next, 24 months, I'll pay you this. I've done it as, just written a check to people. Hey, here's the full amount. I've done bank loans. You can get creative, however you want to do it. So I've known people that have self-funded it through the person they're buying it from, and the person they tack on a percentage, interest rate on it, and they pay them out over time. That's also better for the person they're buying it from, because all the taxes don't get dropped in 1 year. It can get spread out. So, you can get real creative with this stuff, and there's a lot of different ways to do it. There's no wrong way. It's just whatever you can work with whoever you're buying from.
If you go to the bank, do you have to leverage your existing practice as an asset to back up the loan, or how are you backing up the loan that they're about to hand you all this money?
Depends how much it is. so
Sure.
so banks always give you loans when you don't need them. If you don't need a
Yeah.
loan, they'll call you all day, every day.
Mm-hmm.
When you really need a loan, usually it's really tough.
Yeah.
So, it just depends where your financial situation is. So, I've leveraged my own practice. I've leveraged my future collections. There's times that, I've had friends that have also, done a personal guarantee. I've done that too, where you guarantee your own house and your own stuff on it.
Mm-hmm.
And so it just really depends on how much money you're taking out, what your assets are, what your cash flow is. And the key thing is having a good banker. I've worked with several banks, and the bank I'm with right now, they actually have a medical division. And so, Where the old banks, some of them would be like, well, you don't have this amount of money in the bank. This bank goes, well, let's look at your current cash flow. Let's look at, oh, you added this many doctors. Each doctor's been worth this amount of money to you. Oh, this is no problem. We'll approve this in a second.
Mm-hmm.
There's also government programs where, SBA loans, where if you're buying property and the practice at the same time, it's much more insurable, and then they're more likely to let you run on that.
Hmm.
So, the important thing is talking to your lender and having a lender who's not just like getting your loan quick to sell to somebody else, but working with a company that actually cares about medical and will actually work with you on this.
So let's talk for a minute about when you hire a new doctor. I think that's maybe what most people listening are going to be interested in, is how do you structure your contracts? Not necessarily dollar amounts, but like how do you structure it when someone's brand new out of residency? They've brought in $0, so essentially they are worth $0. But they
Right.
think they're not worth $0.
Right. They think they're worth everything.
Yeah.
No, before I say anything, I think a lot of the younger kids need to know that, the first year you're in practice, usually you don't make money for the practice.
Right.
The amount of money that you spend on credentialing, that you spend on advertising, you spend on, transitioning my patients to you, usually the first year isn't a big gain, if anything at all. So, so a lot of our contracts in my practice tend to be commission based. I'm a big eat what you kill person. You want to work hard, great. You don't want to work that hard, then you'll see the fruits of that. Now, that being said, a new doc coming out of practice, I've been there too. You have no money, you have a whole bunch of loans, and they have a lot more loans than I used to have.
Yeah.
And so, we usually start with a salary plus incentive type of program. And then what that does is it allows you to get some money so that you have a good first year. You can start paying back your loans. You can get a decent place to live. You can get your old car switched up, and start getting yourself onto success.
Mm-hmm.
But for me, after that, after the first year, I'm like, all right, we're going to move you to commission, and you better be ready to run at that point. Because if you're not, then you're not going to be a good fit for my practice.
That's just for anyone listening. That's not different than what I've had at both my orthopedic group and a multi-specialty group. Kind of the first year is a little more set in stone, and then after that is pretty variable. Like even right now, I'm in a multi-specialty group. I have no guarantee. It's all completely based on my collections minus all of my expenses, and I get to keep the rest. But I think that's pretty much the most fair pay structure, is basically rewarding people for output. And if you do a good job, then you should, just like if you worked at Best Buy or Target and you pick up overtime shifts, you have worked harder, you're going to make your paycheck is going to be bigger at the end of the month. So I don't think that's too different than most jobs out there. So I want to talk for a minute about private equity groups. It's a very common thing for people who don't understand what we're talking about in America. Recently, maybe over the last 5 to 10 years, it's become very common for private equity groups. Basically, people have no interest in anything medicine, but they do have interest in finances and making money, to come in and buy practices. I know of a handful of people who have gone through this process, and it's been disastrous. What are your thoughts on private equity groups' involvement in medicine, and have you had any experience with that?
So we're currently independent. I'm still 100% owner of the practice right now.
Mm-hmm.
Has private equity approached me? Yeah, sure. I think there's a place for private equity, but I think you have to know what private equity's motives are. Their motives are money.
Right.
And so, what private equity, what their goal is to take a bunch of practices, push them all together into one entity, try to streamline them as much as possible, and then increase the overall income. And, what you have to understand is that if you have a smaller group not making as much, they may, their practice may be worth, 50% of what they collect. If you have a practice that has, 30 people, they may be worth 10 times what they collect. And so there's a multiplier that they work based off of EBITDA. And if you don't, that as, look into that. But, and so what happens is that their goal is to get all these practices together. And what they like to do is usually within like a 3 to 5 year period, sometimes a little longer than that, They like to get as many practices together, optimize them so they can get the most income, and then they sell that for a multiplier, and that multiplier is worth a lot more than what you started with.
Mm-hmm.
And for people looking to not run a practice anymore and to get out of the situation, especially people who are later in their career, I know people that have had some really good stories where they invest and they get a bunch of money. Other people take over everything for them. They just get to practice, almost like a hospital system, but you're still in private practice.
Mm-hmm.
And so there's definitely a place for it in the right scenarios. Um, but depending on the group, sometimes autonomy is lost, sometimes the values are different, and so if you're getting into private equity, you have to make sure that the group's values match yours, the way they treat patients, match yours, because the last thing you want to do is, be getting a call from corporate saying like, hey, how come I saw that you saw a patient with plantar fasciitis. You gave them a shot. They didn't get a night splint. Why didn't you send them to our physical therapy? How come they didn't get orthotics yet? And you're
Mm-hmm.
like, well, that's all the patient wanted. They're like, well, you need to do better with this.
Yeah.
And there's groups that do that. And there's other groups that let you practice the way you want to practice.
Right.
And so
So
it's again, it's one more facet of private practice, multi-specialty group, ortho group, hospital group, private equity group.
yeah, I've known orthopedic groups who sold to a hospital and regretted it. Multi-specialty groups that sold to private equity and regretted it. There are certain people that like it, and those, like you said, are the people towards the end of their career because they can get a large paycheck on the way out the door. But the people who are left behind, it always seems like they were kind of left holding everything together, and like you said, maybe didn't turn out quite like they wanted. So I could see pros and cons, but it just seems to be maybe not everything that you'd wished for when it sounded so good on the front end.
Well, and what
Not
happens to these private equity groups is, small group sells the bigger group, who sells the bigger group. And so, in podiatry, we haven't seen a lot of groups that have sold to the next level yet. And
mm-hmm,
so, as far as how this is going to end up long term, I don't think it's fair to say we're going to know. Now, this model worked really good with dental.
mm-hmm,
Dental was doing this, 10, 15 years ago, and they were selling up and getting bigger. And that's where you have these Aspen Dental and some of these other places that
mm-hmm.
are these mega groups. And there's people who go there and like working there, and it's good. And there's people who made a lot of money off of them. So again, I think there's a role for this, and I think for people in the right scenario that these are probably good situations. Other people, if they're expecting a certain thing and it doesn't match with what they want, then it may not work out that way.
Sure. So let's switch gears to fellowship. Talk about your involvement in fellowship. Gonna give it a description of what you got going on there.
Yeah, so we have the Northwest Illinois Foot and Ankle Foundation Fellowship. So we have a fellowship program approved through ACFAS. We've had that for 6 years now, I believe. And we've been able to, train a lot of people and get them to see how kind of advanced training works.
So what would they expect to kind of be involved in? How many physicians are they working, or attendings, I guess you want to call it? I guess we still call that in fellowship. I'm not sure. How many docs are they working with, and what kind of stuff are they doing?
Well, our program is built within our practice and another practice also. And so, they have access as far as attendings go to about, 20 some attendings. And they cover a lot of cases, but within our two practices, the fellow probably covers less than 40% of the cases. There's so many cases going on that you can't cover them all.
Mm-hmm.
And so the fellow gets to kind of choose between the cases they need, and they want to see. I have guys that come out of fellowship and haven't done a lot of scopes, and then I have other ones like, I've done a ton of scopes, but I need to do more flat foot recons. I've only done a few of those. And
Mm-hmm.
so we kind of tailor the program based to what they need and what they're looking for. We have components where we work on research also, and a lot with clinical skills too. I got a lot of clinical training when I was a resident, but I've had other the residents that come out and they were too busy trying to chase cases, and they don't know how to work up stuff or don't know how to deal with complications, but they can be a technician and do the surgery.
Yeah, I think that's one of the bigger downsides that I see in certain residencies is that they get out and they can do all the surgery, but they don't know how to decide which patients are optimal for which procedure selection, and they don't know how to manage complications. They don't understand billing and coding and modifiers and all this stuff. So I think that's an undervalued part of our profession. And so I would imagine with you being in private practice, do they get some exposure to some of that stuff as well?
A ton. So
Yeah.
from day one, I tell them, you're going to learn a ton about surgery, but you're going to know so much more about billing and coding, how to manage patients, the way to optimize care plans for patients, and picking the right DME for them. And one of the hardest things we deal with is when patients have complications, even if they're not your fault, and it's looking them in the eye and saying, "This is how we're going to deal with them. This is what's
Mm-hmm.
going on." Being honest with them and saying, "This problem happened. Neither of us wanted this. This is how we're going to deal with it." And if you're in a program where you're just scrubbing cases and never seeing people afterwards, you assume everything went okay every time. And so dealing with those problems and working through those, again, that's one of the hardest things we deal with in practice. And so we work with that on top of all the billing and coding stuff also.
Yeah, that's great. I think that's a very undervalued component of, these residents, they say, "Oh, I want to do surgery, surgery, surgery." Yeah, fine. Okay, do it, learn it. But you're undervaluing what most people do 90% of the time. 80 to 90% of the time is not spending the OR. It's figuring out who is going to go to the OR. So I think anyone listening, that's an undervalued component. So just keep that in mind. Um, Anything else that you'd like to touch on?
No, I still think there's a lot of I think we still have a great profession. I hear some people getting down on it at times, but I think they don't realize that this is just kind of all of medicine right now.
I
You
think
know,
it's every profession. I think if you listen to anyone who worked at the grocery store or Kohl's or whatever, they would all be complaining also. So it's the people, not the profession, in my opinion. But keep going.
but I think the biggest point of all this is that the people who are the happiest and are doing the well are the ones that adapt to the times. I know docs that were working in the '80s and '90s, and they were getting paid $4,000 to do a bunion, and to this day, that's all they complain about is that I used to get a ton of money for what I do. They're not paying me anything anymore.
Mm-hmm.
And the docs who have adapted and realize, hey, we got to work on these EMR systems. Hey, coding's changed. Hey, how we manage this is different. Hey, the rules for DME change. And if you stay up on this and learn this harder than you learned anything in residency or in school, you can stay up on this and be very successful and rise to the top. But it's amazing to me, how many doctors don't know some basic stuffs about billing and about coding and about, you need a standard written order when you give someone a piece of DME. Well, what's that? I've never done that in my whole career for the last 30 years. And it's like, well,
Mm-hmm.
they can come back and take any of that money back because you have to have that.
Mm-hmm.
And the biggest thing I think is when people, I've been at conferences where people said, "Oh, if you do this, you can get paid for this," and then people go, "Well, I'm doing this," and they don't research it on themselves and say, "Yes, you can do this, but it has to be under these terms. You only got half the information." Or people tell you, "Oh, I've been doing this and it's been working." Well, yeah, but that's not right. You've been getting paid, but then when they come back and ask for all the money back later, you're going to be sitting there crying poor. So
Mm-hmm.
you have to really take this as you go from medical school, you learn everything there, then you get into residency, you don't know anything again, and you got to start all over again, and then you get into private practice, and it's like you don't know anything again. But
Mm-hmm.
you can't be like, I've hit the finish line. You really have to continue not only with your surgical training, your medical education, but also with your business development.
Yeah, I agree. So what's your goal number of practices? You gonna keep growing?
I don't have one.
Yeah.
If you'd asked me 10 years ago where I thought I'd be, I'd probably be talking about maybe I would be opening up my second office by now.
Yeah.
And my goal has always been kind of steady growth, but good decisions. There's physical therapy corporations out by us that are like, we need 35 new clinics this year, and they do whatever they can to open 35 new clinics, knowing a bunch of them are going to fail, and just see what happens.
Jeez.
For me,
Yeah.
it's about finding good people. It's about finding good opportunities. And if I've got good people and good opportunities, we'll be successful.
Sure.
And anytime you try to force things, it doesn't always work as well. And so, if I never buy another practice or open up another practice, I'll be happy.
Mm-hmm.
If we have continued growth, I'll be happy too. It's more about just, you know, good people, good service, and the rest comes with it.
Yeah. Absolutely. I think those are good thoughts. So thank you very much for joining me tonight on Pod Patrol.
Thanks for having me.
Yeah, I think this will be really helpful for especially the younger people looking into different practice models, because even I learned a lot tonight because I've never been involved in private practice. So thanks for sharing all the kind of peek behind the curtain and all the details.
Great, thank you. And if anybody's looking for information on our practice, it's illinoisfoot.com, Northern Illinois Foot and Ankle Specialists.
All right. And then the name of the fellowship?
Is the Northwest Illinois Foot and Ankle Foundation Fellowship.
All right. Sounds good. People will be looking for it. Thanks, everybody, for joining me on this episode of Paw Patrol with your host, Dr. Jeff Dykes. We'll see you guys next time.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.